the audio network, and hopefully everyone can follow along the slides that are up. Today we're going to be addressing the next set of meaningful use objectives, and they relate to patient data for the most part. And so we've tried to group these as best we can to go through them and have kind of a relevant grouping for you all. Again, we're dealing only with the requirements that are for hospitals and critical access hospitals, even though some of these are very similar to the EP objectives as well. So just note that. We'll be covering a total of 5 objectives today, 3 that are core and 2 menu. So that's on the agenda. And as Carol mentioned, we'll have a Q&A at the back end of this. So if you have some questions or I wasn't able to clearly state the objective and measure for you, go ahead and use the Q&A section of the window and send in those questions, and we'll try to get to them at the back end of this. Okay. As you may know, if you were on yesterday, there are several slides that are similar that we're grounding the objectives off of, so bear with me if you saw these yesterday and know them by heart. But as you know, for hospitals, there are 24 total objectives, excluding the quality reporting requirements that they have to meet as well. We can think of these as being also grouped in 5 priority outcome areas that the HIT Policy Committee identified back in 2009. And those 5 are showing on your screen now, improving quality, safety, and efficiency. That one probably grabs the most attention. Engaging patients and families in their health care, trying to get some self-management of health care to the patient level. Making sure that health information is protected, secure, the privacy component of personal health information. And then improving care coordination amongst healthcare providers is a critical one that's obviously very dependent on some technology layers that are just now being addressed. So, that's one that will probably take more benefits as we get out in the technology. The health information networks are rolled out. And then finally, improving population and public health on a more of a, quote, global basis as far as reporting information to agencies so that they can have as early an alert as possible on any outbreaks of certain types of disease. So those are the 5 priority outcome areas, and really are used just to talk and set a framework for what specific objectives ought to be included in the EHR incentive program by stage. All right, as I mentioned, there are 14 core objectives for stage 1 for hospitals. Core meaning they have to be met, so there's no wiggle room on those. And excuse me, and those are we'll note which are core and which are menu as we go through. And one of the decisions that hospitals are going to have to make are on the menu items, but the core, they don't have any decisions. They have to be met. All right. As I said, menu make up the other 10, so the 14 plus 10 is how we get to the 24 objectives. And on these, there are some decisions that can be made and some strategy that ought to be considered for at the hospital level. And you start out by saying you only need to meet 5 of 10 of these menu objectives. So the 14 core plus the 5 that you have to select, leaving, giving you a total of 19 that you have to meet. So you actually, the way that it's worded is you defer 5, and then so you have 5 remaining that you're supposed to meet. However, if you can exclude yourself of one of those remaining 5, then you don't have to bring back one that you deferred. So you end up not having to meet 19, but maybe 18. And we'll show you an example today where we actually have a menu item that can be excluded. So that's the way that the structure of the menu objectives are. You'll note on the slide that of the 5 that you have to select from if you've deferred, one has to be one of those public health priority objectives. So that's a requirement as you select the menu items. All right, so that's the structure of the objectives. Now, as we did yesterday, there's a structure in which we'll talk about each objective. The objective description will then make sure that the measure is understood. How do you determine whether you're, quote, compliant with that objective? And that's how you evaluate yourself, and that would be the measure. And then note any exclusions. You know, is there an exclusion for this objective, and if so, what is it? What's the circumstance that I would not have to meet that particular objective, but still be able to, quote, qualify for the EHR funding, incentive funding? All right, so from a measure standpoint, there are several measure types. The easiest one is attesting that you have met a specific measure. You don't have to provide any numerical information. You just state, I met that particular measure, and you self-attest to that. The second type of measure is based on a percentage of compliance of the measure that your particular hospital meets. And there's a threshold, a number value that you have to exceed in order to be compliant. So from a calculation of a percentage, you need a numerator and a denominator. So the denominator is basically the population, total population that is included in the measure. And typically there are 2 different denominators that can be used. Those patient records, or those patients whose health record are maintained in the certified EHR, that can be one type of denominator. Second would be all patients seen or admitted during the reporting period, regardless of whether their records are kept in the certified EHR. So one is, I guess you can think of it as a subset of the other. You have total patients, or only those patients whose health information is maintained in the certified EHR. The numerator is going to be those patients of the denominator that meet the objectives. And clearly we'll see those types of identified in the objectives as we go through the examples of those. So once you get the numerator identified for those patients who, let's say it's patients, who meets the condition of the measure, then you can calculate the percent and determine if you're above or below the metric. And remember, one key thing about all these metrics, the hospital has to meet all of them. There's no partial pay for partial meeting of measures. So you have to meet 100% of the measures to get any funding. If you only meet, let's say, 18 of the 19 measures, you're not going to get any pay, so, or any funding from the program. Okay, so that's the measures. I mentioned exclusions, and there's a recognition that in certain institutions, there may not be a patient population that would qualify that institution to meet that particular objective. So CMS has recognized this and identified on a small subset of the objectives exclusions that the hospital can attest that they do not have that particular patient population and therefore are excluded from having to meet it, and they can still qualify for funding. So when I just said that you have to meet all the requirements, or objectives, you have to meet all of them unless you are able to exclude based upon the exclusion that CMS has predefined. Okay? So, again, trying to make this clear structure before we actually get into specific objectives. So, what we're going to do is cover recording patient data in the certified EHR, and we all know we have to have the certified product from HHS, from an authorized testing and certification body. That's the technology we have to use in order to qualify, and then we have to meet all of these objectives. So there are some terms that we need to make sure that we're comfortable with and familiar with in these definitions that we'll run across. And one of the key ones that came up early and CMS recognized they needed to clarify was which patients that are seen in the emergency room qualify to be included in the denominator and numerator. So there was an adjustment after the final rule. There's two methods that are now allowed: the observation services method, and what that includes are those patients who are seen, in the emergency room and subsequently admitted to the hospital. They obviously would count, but then also those patients who are seen in the emergency room, and if there's an observation unit or clearly observation services that are received by that patient, then they would also go into the qualification of being included in the counts. The patients are then, as I said, included in the calculation of the percent if their observation services method is used. The alternative is to include all the emergency department visits in the denominator. Now, this may or may not help your calculation, and I think hospitals have to look at this and determine if I'm getting a bigger denominator, that means that my percent might go down if I don't have a subsequent increase in the numerator value of those patients, all patients who go through the ED meeting the measurement requirement. So there's a strategy point here, and hospitals have to look and assess their caseload in an emergency room and determine if they're better off measuring only through observation services method or using the all emergency department visits method. Okay, so it's not just you're telling you what to do; they're giving you a choice. The term unique patient, which I think many of you hopefully are becoming familiar with, all that means is during the reporting period, and the reporting period is the period in which you have to be compliant with all of the objectives that you are to meet, so typically 19 of them. You have to be compliant for the whole reporting period. The reporting period for year one under Medicare is a 90-day contiguous period, and that for Medicare, it's during for hospitals, it's the fiscal year of the government, so October 1, 2010 to September 30th, 2011. Any contiguous 90-day period during that interval, during that fiscal year, could be a reporting period, and so that's important. The reason I bring it up is unique patient means that during the reporting period, if a patient, the same patient, is seen multiple times, they're only counted once for measurement purposes. And so it's important to be able to identify that situation, and your EHR, certified EHR, has capabilities that help measure that and be able to identify recurring visits and eliminate or exclude those from calculation. And so that's why unique patient is important. Another term, preferred language, and that just is what is the language that the patient would like to be communicated with, but it certainly isn't a requirement that you have to meet that. It's just a preference. Okay, so let's start reviewing specific objectives. And the first objective we're going to look at is a core objective, meaning we have to meet this if we're going to qualify for payment. And it's just capturing, recording the demographics of a given patient. And again, preferred language is one of those attributes that needs to be recorded, along with gender, race, ethnicity, date of birth, and this is, so those are all the same if you're looking at an eligible professional, let's say. However, for a hospital, they also need to be able to record date and the preliminary cause of death, and that is, so again, that's unique to a hospital setting. So that's the objective, record that demographic information. What's the measure? All right, the measure for that is that more than 50% of all unique patients, so there's that term, unique patients, that are admitted to the eligible hospital or a critical access hospital, to either the inpatient or the emergency department. There's the emergency department, and why we wanted to make sure the definition of patients that are counted there is understood. Have this demographic information recorded as structured data. So the structured data you will see is a recurring theme throughout these objectives, and obviously the reason it's done is to help in either analytics or lookups, so that alerts can be triggered, or patient lists of certain conditions or certain backgrounds can be generated for analysis. And you'll note that there are no exclusions for this particular objective, and it's a core objective, so I mentioned earlier they have to meet all of those, but we'll still note that there are no exclusions for record demographics. So again, what are the attestation requirements? And you'll actually have to submit the denominator number and the numerator number, specific values, to CMS when you attest or submit for funding after you have gone through your 90-day, in the first year, your 90-day reporting period. And what you're doing is number of unique patients admitted to the hospital or seen in the emergency department if you're using observation services, etc., during the reporting period. And the numerator would be the patients who you have captured all of the demographic attributes, and you can exclude if a patient declines to provide one, maybe ethnicity or something. You can note that, and that still is acceptable. The result has to be you have to have more than 50% of those unique patients recording that particular information, that demographic information, in order to meet this particular objective. Okay. So, where do you get some of these codes? Race and ethnicity. There are standards that are out of the Office of Management and Budget, and there is of course, a website that you can go to get those codes and look them up, and they are contained in this the URL that appears on the screen. I mentioned that if a patient does decline some of that data, that to answer some of that data, that you can note that as structured data in order to be compliant. Similar to if they don't know an answer, they may decline or they may just not know it. You would record it similar to if they had declined to provide that information and you still would qualify. I mentioned earlier, providers don't have to communicate in the preferred language. Obviously, it might be very difficult to know all the languages that might be preferred. But it is there just if there is an ability to communicate to them in a preferred language, that they have the opportunity to know that. Excuse me. And then finally, cause of death, I mentioned was preliminary. There's no requirement to go back and update that based upon maybe a change in cause of death from the coroner's office or Department of Health. You're putting in the preliminary assessment only. Okay. So let's move to a second patient information, patient data objective. Again, a core objective, meaning we have to meet this particular objective, and that is recording vital signs, which in the definition of CMS, as far as what we need to capture, would include height, weight, the blood pressure, and then be able to calculate and display the body mass index. And then for children, be able to plot and display growth charts for children between certain ages, between 2 and 20. And so that's the objective. That's the kind of data that has to be captured. Again, we're looking at being able to do that more than 50% of the time for unique patients. Now, those patients need to be age 2 and over, so there is a qualifier, and admitted to the hospital again or seen in the ED, and there are no exclusions for this particular this particular objective, and it is it's similar to the to an EP requirement as well. Okay, the attestation requirements. In other words, what do we have to do to prove this one? We have to be able to get the number of unique patients that are in that age range, 2 or older, admitted to the hospital as seen in the emergency department during the reporting period. And again, the EHR, certified EHR software is supposed to generate that information because that's how the certification criteria were written. Then it's the number of patients who have at least one entry of their height, weight, and blood pressure are recorded as structured data. So that's, if we get more than 50% of those patients and then we've recorded the height, weight, and blood pressure, then we'll be compliant with this particular objective. And so, again, it's the way it's worded, more than 50%. So if you're 50%, the way I read it, you do not qualify. You have to be at 51%. Okay. Now, some additional information for you. The provider can limit those patients whose records are maintained in the certified EHR. In other words, for the denominator, just use those patients whose records are maintained in the certified EHR. If for some reason the hospital has some patients who aren't recorded in the certified EHR, they don't have to include those in the calculation. The certified EHR technology, the specification is it needs to be able to calculate the body mass index and generate growth charts appropriately. So the data that you have to only input would be height, weight, and blood pressure. And that you don't necessarily have to, at each event during a stay, have to, or encounter during a stay, have to update that information. The provider has the latitude, and I think procedurally, again, this is where the mechanics of the program have to be balanced with process and workflow within a hospital to determine, where's the right point to do the capture and how often do we need to update based upon maybe length of stay or the type of condition that might be incurred or by the patient would help dictate the frequency that information gets updated. So that's up to the provider to determine that. And the information's got to be entered as structured data. One other point that if you're unable to, for some reason, measure height because of some condition, you can't have the person stand to measure. Approximations are accepted. So that's common sense, but just they do spell that out as well. The information, some providers wouldn't necessarily capture this type of information, and that's more on the EP side. They just need to be able to have it available if they don't capture it typically when they see a patient. They just need to be able to have reference to it. In a hospital setting, however, you do need to capture it. Okay. Getting at another core objective, and that is record the smoking status for, again, they limit the population requirement to capture it for patients 13 years and older. And in one of my discussion groups, I don't know when this was, probably 6 months ago, they said, smoking status of what? Is it tobacco or something else you're smoking? So the assumption is it's tobacco smoking. Measure, again, is more than 50% of unique patients, you are capturing the smoking status, and it's recorded as structured data, and there are some codes that have been defined for that. Again, for inpatient and emergency department patients. Now, we do have an exclusion here, and it's a core objective. If you're an eligible hospital and you do not admit patients that are 13 years old or older to point of service 21 or 23, and that would be during the reporting period. And I don't know how a hospital would be able to survive if they aren't, unless they're pediatric, and then I'm not sure how they qualify for Medicare. But then you're excluded, and you would not have to meet this objective, but you would have to state when you are attesting through the attestation system CMS has developed that you have no patients and therefore no numerator denominator that would be included, and you would still be able to be compliant with the overall EHR incentive program if you're compliant with all the other objectives. So that's the way the exclusion could work here. All right. Now, the denominator is going to be just, again, a count of those patients who are 13 years or older seen are admitted as inpatient or seen to the emergency department. And the numerator is very straightforward. Of those patients, how many were recorded the smoking status and structured data. So, as I mentioned, the way in which the exclusion works, and the hospital would select no to the appropriate exclusion and be able to apply it in order to attest to the exclusion. So you still have to answer a question about it in order to qualify. You can't just ignore that particular objective. Again, you have to be greater than 50% in order to qualify. Okay. Some additional information. Again, this is one where you can limit those patients in the denominator to only those patients whose health records are recorded in the certified EHR. And if my math is correct, I think that probably, unless you have more patients outside the EHR who you track their, I don't know how you couldn't track it as structured data in the certified EHR. So it wouldn't seem to me to make sense to include patients outside of the certified EHR in the calculation. It's going to hurt your percent. Excuse me. So if the information has already been recorded, there is some latitude on frequency of updating, similar to some of the other patient information, where if the patient is transferred from inpatient to surgery, back to ICU, back to inpatient, somehow do we have to ask smoking status at each stop? And common sense says if you're there for a singular event, that if you've updated that information for that visit, then you probably are fine as far as is that information current. So they're allowing for some procedural workflow common sense to be applied. All right, now we've got one of the two menu objectives. Again, menu objectives can be, quote, optional to you. You have to select, you can defer 5, and then of the remaining 5 you have to meet, unless somehow you can exclude. So this is one of those menu objectives, and that's recording advanced directives. And what they mean by recording advanced directives doesn't mean that you actually physically, electronically have the advanced directive in the EHR. What you're doing is recording the fact that there is an advanced directive that the patient has completed and would be available as appropriate. So they're only looking for patients 65 and older to do this for, and the measure is more than 50% of unique patients 65 years and older. Again, for the inpatient, and this is one where this is one of the very few that doesn't include emergency department, and I've yet to totally understand the rationale, but have indicated that they have an advanced directive, and you've recorded it, the status of whether an advanced directive exists has been recorded as structured data. So here there's an exclusion, somewhat similar to the smoking, where an eligible hospital, if they haven't had any patients who are admitted who are 65 years old or older during the reporting period, could exclude on this particular objective because of no patients seen during that time period. Again, very similar denominator approach of the number of unique patients, 65 years or older, and they are admitted in inpatient department. Again, that's a difference here from some of the other measures. And so that's the denominator. The numerator would be that we've captured the status of the advanced directive as structured data in the patient's electronic health record that's in the certified system. A similar exclusion approach where if there haven't been any patients during the reporting period, and again, first year it's 90 days, the second year it's a full 12-month concurrent with the fiscal year for hospitals at the federal level, the fiscal year. And all they would do then is to note that no to the appropriate exclusion and then apply that in the CMS system for when they go to attest to gain funds. The resulting calculation has to be greater than 50%. All right. Excuse me. Again, this is one where you can limit your denominator to those patients whose records are maintained using certified EHR technology. This one, the recording of advanced directives may not be permissible in some states under existing state law. In order to satisfy the measure of this objectives, providers need only record the indication that an advanced directive exists. Now that's really all you need to do. I mean, you don't, the actual capture of the advanced directive into the EHR is not required. I think I meant to say the calculation does not include, emergency room patients, and that. Okay, so I think we've said that enough times. All right. And finally, so that's advanced directives. All right. So finally, the second menu objective that we're covering today has to do with clinical labs. And so what this requirement states, or objective states, is that we need to incorporate clinical lab test results into the EHR structured data. But it's certain types of lab test results. So probably worth just maybe reading the measure itself. Again, more than 40%, okay, so greater than, of all clinical lab test results that are ordered by an authorized provider of the eligible hospital or CAH for patients admitted to inpatient or emergency department. So we go back to, now we've got both inpatient, point of service 21, and emergency department, point of service 23 are included during the EHR reporting period. Always have to qualify for that. And here's the qualifier for which types of clinical lab test results are included. And those are ones that are, the results are either in a positive or negative form or a numerical format. And those are the results that are included in this objective. And those that have to be incorporated into the certified EHR as structured data. And for this, there are no exclusions. Okay, the numerator, the denominator, again, it's the number of tests ordered during a period whose results can be expressed in positive or negative. So it's that subset of lab tests that are ordered, and the numerator would be the results of those that are expressed in positive, negative, or numerical that are included or incorporated as structured data. Fairly straightforward. Now, it might get tricky which lab test results the system can identify that have the results, the labs have the results in positive, negative, or numerical. And I don't know how we flag those. You're going to sort that out. So that's a process point. The resulting percentage has to be greater than 40%. Okay. Again, the measure, you have the option, I guess, of just taking those patients whose records are maintained using certified EHR technology. You don't have to exchange the results in order to qualify. The eligible hospital is not limited to only counting structured data received via electronic exchange. In other words, they can manually enter it. It's just got to get into the certified EHR record. Now, obviously, from an efficiency standpoint, the hospital is going to want to try to interface those results as often as possible. Okay. That really covers, I think, this particular objective for the most part. That we have a final point here about lab results are not limited to any specific type of laboratory or to any specific type of lab test. It's just the results have to be expressed, positive, negative, or numerically. That's the only qualifier. Now, the actual objective that was stated by CMS didn't specify a particular code set. However, the Office of the National Coordinator, when they defined the certification criteria and standards, did adopt the LOINC code structure as one that is acceptable. So, there's two components that you have to sometimes look at to understand what is the total requirement set, including objective, measure, and then any standards that are recommended or required, and that being the final rule on objectives and then the final rule on implementation standards and certification criteria that the Office of the National Coordinator published. So that's what this particular point is addressing. It's saying even though the incentive program in its final rule didn't specify a standard, the Office of the National Coordinator did.